Ok, vamos a comenzar. Estamos Eric, Miguel y Ricardo. Entonces, como quedamos, vamos a ver estas últimas dos presentaciones, ¿va?
Sí, doctor. Doctor, no se escucha.
Sí, perdón. Regreso un poco.
Masitintam plus tadalafil plus. These are my disclosures. Initial double oral therapy with an endogenous receptor antagonist and the PD5 inhibitor is recommended for newly diagnosed PAH patients at low or intermediate risk of death. In patients treated with an endogenous receptor antagonist and the PD5 inhibitor, addition of selexipag further delayed disease progression. Triton evaluated the efficacy of initial triple oral treatment strategy, masitintam plus tadalafil plus selexipag, versus initial double oral treatment strategy, masitintam plus tadalafil plus placebo. Here we investigated the efficacy of initial triple oral therapy versus initial double oral therapy on long-term outcomes. This is the design of the study. After a screening period of up to 28 days, patients were randomized to initial triple oral therapy and initial double oral therapy. Patients were all newly diagnosed and treatment naive. At weeks 26, the two primary endpoints, pulmonary vascular resistance and 6-minute walking distance, were assessed. And then the patients were followed in the blinded fashion up to the end of the main observation period, according to the intention to treat principle and irrespective of discontinuation of study treatment. So the end of main observation period was when the last randomized patient reached week 26. And these are the study endpoints. Primary endpoint is the change in PVR at week 26. Secondary endpoint was the change in 6-minute walking distance at week 26. And disease progression was assessed in the blinded manner by 3 different analyses. First, the time from randomization to first adjudicated disease progression event up to the end of main observation period plus 7 days. And this was an official secondary endpoint. Then, by all adjudicated disease progression, and I outline all adjudicated disease progression events up to the end of main observation period plus 7 days. This was a post-hoc analysis. And then also time from randomization to all-cause death up to the end of main observation period. Disease progression was assessed by one of the following points: all-cause death, hospitalization for worsening of PAH, initiation of approved treatment targeting the prostacyclin pathway for worsening PAH, and clinical worsening as defined as the decrease of more than 15% of 6-minute walking distance from the highest 6-minute walking distance obtained at or after baseline and WHO functional class 3 or 4 symptoms. All disease progression events were adjudicated by the Clinical Events Committee. And these are the demographic and baseline characteristics of the two groups. The average age of the patients was 52 years around, and the time from diagnosis to the inclusion of the study was quite short, about 20 days. I remember that all patients were treatment naive. 50% of the patients were idiopathic and 35% were associated with connective tissue disease. The average baseline pulmonary vascular resistance was around 12 Wood unit, and the baseline cardiac index was quite low, from 2.1 to 2.2 liter per minute per square meter. And these are the primary and secondary endpoint. PVR were reduced in the initial triple therapy group by 54% and were reduced by initial double therapy by 52%. The difference is not statistically significant. The secondary endpoint, 6-minute walking distance, was increased by 51 meters in the initial triple therapy group and by 56 meters by the initial double therapy. And also this difference is not statistically significant. Then analysis of the outcome. These analyses are considered exploratory because the primary and secondary endpoint were not statistically significant. And this is the time to first disease progression event up to month 30 from enrollment. And as you can see, there is a trend to lower number of events in patients in the initial triple oral therapy group. 85% were event-free at around 30 months, and 74% were event-free in initial double oral therapy. The difference is not statistically significant. And this is the analysis of the rate of all disease progression events. In the initial double therapy group were 67 the events as compared to 31 in the initial triple therapy. And this difference in favor of the triple group were observed in patients with at least one event, in patients with at least 2 events, and in patients with at least 3 events. The difference are not statistically significant. And these are the single events. As you can see, the reduction in the first disease progression event is observed mainly in the hospitalization and in the deaths. The same phenomenon is observed when all disease progression events are assessed. The reduction is mainly due to reduction in hospitalization and reduction in mortality. And this is the assessment of time to all-cause death. Also in this case, there is a difference in favor of initial triple oral therapy, 98% survival at 30 months as compared to 91% in the initial double oral therapy group. Also, this difference by 77% is not statistically significant. And finally, safety. As you can see, the number of adverse events were similar in the two groups, while the exposure was longer in initial triple therapy group. And the most frequent adverse events were headache, similar incidence, diarrhea, more incidence in the triple therapy group, and nausea, more frequent in the initial triple therapy group. In conclusion, in the Triton, hemodynamics and functional capacity were markedly improved from baseline with no difference between treatment strategies at week 26. Exploratory analysis on time to disease progression, a secondary endpoint, suggested a signal for improved long-term outcome with initial triple versus initial double oral therapy. Post-hoc analysis, including assessment of all disease progression events and all-cause deaths, are consistent with this finding. Triton is the first randomized control trials to examine all disease progression events rather than first event only, providing further information on outcomes relevant to prognosis and quality of life. And these are the members of the steering committee of the Triton study and the members of the clinical event committee, of the independent data monitoring committee, of the independent liver safety data review board, and also a list of study investigators. Thank you.
Ok, a ver, me perdí, no me recuerdan cuál fue la triple. Una cosa acá. La triple. El comparador fue, recuérdenme, fármacos, ¿cuáles fueron? ¿Sí me escuchan? Miguel, Ricardo, ¿ahí están? Poncho, ¿me escuchan?
Doctor, se acaba de escuchar el que dijo Ricardo y
Ya,
Juan, pero
ya
antes.
lo escuchamos.
¿Sí me escuchan? No.
Es que escuchaba como...
Ya se escucha bien.
Ah, ok. Nada más recuérdenme los fármacos, los que compararon, que no me fijé, no. ¿Cuáles eran? Vamos a ver.
Era más
Insights.
Ajá.
Y tadalafil.
Tadalafil.
Ajá. Y luego se les agregó Selexipag o placebo.
Ok. Uh-huh. Muy bien. Sí, yo creo que ahí nada más tener ahí, obviamente pues está muy complicado, ¿no? Creo que en todo caso podríamos iniciar tadalafil.
Sí.
Y ya. Perfecto. Pero así grandes diferencias, no, ¿verdad? Aquí en el primary outcome. Y sí más efectos secundarios, ¿no?
Sí.
Uh-huh. Ok, vamos a revisar el último. El último es este, Achieving Best Long-Term Outcomes in Pulmonary Arterial Hypertension, How to Choose the Right Treatment and When to Start them. Muy bien, vamos a revisar este.
Thank you, Stefan, for your presentation. And these are my disclosures. And pulmonary arterial hypertension is a group of rare diseases with a prevalence of 60 cases per million. They are heterogeneous but there are common findings like the distal pulmonary vascular disease, a precapillary pulmonary hypertension, and dilatation of the right heart chambers. And from a pathobiological point of view, we are able to address three pathways. The endothelin pathway, using oral endothelin receptor antagonists. The nitric oxide pathway, utilizing oral PDE5 inhibitors and soluble guanylate cyclase stimulators. And for the prostacyclin pathway, a more heterogeneous way to address this pathway. We have prostacyclin analogs and a new class of drugs, non-prostanoid prostacyclin receptor agonists. These drugs were utilized many years ago, and for the epoprostenol, the first published study in humans is from 1984 in a lady with idiopathic pulmonary arterial hypertension. For bosentan and for sildenafil, the first in men studies were published in year 2000. And since then, 41 randomized control studies have been performed for addressing these pathways and utilizing also different treatment strategies. We utilized monotherapy versus placebo or versus another monotherapy. We utilize monotherapy and initial combination therapy. And finally, we utilize also initial combination therapy versus therapy. And also, the design of the studies evolved. At the beginning, we utilized as primary endpoint exercise capacity by 6-minute walking distance. This required short studies and relatively small sample size. And then we evolved into outcomes trials, which have more information, and they require to be longer and larger as compared to the sample size. And this is the evolution of the number of drugs who have been approved up to 11. However, as you can see, the pathway who have been addressed has remained the same since years 2003. These are the names of the drugs currently available: endothelin receptor antagonists, PDE5 inhibitors, soluble guanylate cyclase stimulators, prostacyclin analogs, and prostacyclin receptor agonists. And this is the sequence and the evolution of the treatment strategies. So we utilized the same drugs, but in a different way, trying to optimize their effect. And let's start with sequential combination therapy. This is the example from the Seraphine study. The addition of macitentan to patients on background therapy with PDE5 inhibitors reduced the number of deterioration events as compared to placebo. The risk reduction of deterioration events was 38%. And recently, the orally available prostacyclin receptor agonist selexipag has been approved, and this is addressing the prostacyclin pathway, reproducing vasodilatation and antiproliferation distal pulmonary arteries. And this is the Griffon study with selexipag. And in patients on background therapy with endothelin receptor antagonist and PD-5 inhibitors, the addition of selexipag as compared to placebo reduce the number of deterioration event by 37%. So triple sequential combination therapy is effective when compared to double sequential combination therapy. And this is true in patients with mild symptoms, functional class 2, and patients with more advanced symptoms, functional class 3. And paradoxically, the best reduction of deterioration events is observed in patients at the beginning of their disease as compared to patients already advanced. This outlines the importance of early treatment with triple combination therapy, even when it is sequential. What about initial combination therapy? This is applied in newly diagnosed and treatment-naive patients. Starting with 2 drugs, an endothelin receptor antagonist and PD-5 inhibitors, reduced the number of deterioration events as compared to starting monotherapy. This is true also for macitentan used in initial combination therapy. There is a clear and large reduction of PVR utilizing this strategy, and also an increase of 6-minute walking distance. And now the most recent proposed strategy is the risk-oriented treatment strategies. In fact, in the new ERS and ESC guidelines, the last one proposed, we have a table with the risk stratification of patients with pulmonary arterial hypertension divided in low risk, intermediate risk, and high risk. And according to different variables of clinical evaluation, of measurement of exercise capacity, and evaluation also of the right ventricular function. According to this stratification, the treatment algorithm will suggest which is the best treatment strategy. And this risk stratification has been validated by 3 retrospective registry analysis: the Swedish registry, the Compara registry, and the French registry. As you can see, the stratification is quite relevant according to the risk. And this is the table of the guidelines recommending risk stratification before starting therapy, and utilizing treatment as treatment goal, the low risk profile. So we have to upgrade therapy unless our patients reach the low risk profile. And the level of evidence, which was expert opinion when the guidelines were published, will be upgraded in the next version of the guidelines to level of evidence B. And just to briefly remember the treatment algorithm proposed at the last 6th World Symposium on Pulmonary Hypertension, after identifying vasoreactive patients and treating them with calcium channel blocker, we take care of the majority of the other patients And in those who are at high risk, we need to start initial combination therapy using intravenous prostacyclin analogs. For patients at low or intermediate risk, instead, we can start initial oral combination. A minority of patients will utilize monotherapy. But after this initial therapy, we need to check which is now the risk of the patients after 3 to 6 months. And if the patients have reached the low risk designation, this treatment is continued. Otherwise, we can upgrade the treatment to triple sequential combination. And this may be also oral, utilizing selexipag in addition to PD-5 inhibitors and endocrine receptor antagonist. And if even with this configuration, the patients remain in intermediate or high risk, at this point, we need the triple combination therapy using intravenous or subcutaneous prostacyclin analogs and listing the patients for lung transplantation. These are the residual role of initial monotherapy, responders, patients with calcium channel blocker, elderly patients, veno-occlusive disease, Eisenmenger, HIV or portal hypertension, and very mild disease. And now a new proposal. Shall we start with initial triple combination therapy? This was the question of the Triton study comparing initial triple oral therapy, masitinib, tadalafil, and selexipag, as compared to initial double oral therapy, masitinib, tadalafil, and placebo. The primary endpoint was assessed after 26 weeks, and then the event evaluation, the progression of disease parameters were assessed at the end of main observation period. And the primary endpoint showed an important reduction of the pulmonary vascular resistance and improvement of exercise capacity by both in both groups of the patients. So the primary endpoint was similar in the two groups. But when the outcome and deterioration event were analyzed, there were more event-free subjects in the triple oral therapy group, 85%, as compared to the patients in the initial double oral therapy, 74%. And when the time to all-cause death was analyzed, the event-free survival was 98% in patients in initial triple oral therapy as compared to 91% in the double initial combination therapy. And the key take-home messages of this presentation are as follows. Multiparametric risk assessment should be undertaken at diagnosis. Most PAH patients should begin on double combination therapy. Only a residual role exists for initial monotherapy. High-risk patients shall be treated with initial combination therapy, including intravenous prostacyclin analogs. Risk assessment should be undertaken at follow-up every 3 to 6 months. Treatment should be intensified to triple sequential combination therapy in case of persistence or progression to intermediate or high risk. Exploratory analysis on time to disease progression in Triton study suggested a signal for improved long-term outcome with initial triple versus initial double oral therapy. Thank you.
Ok. ¿Me escuchan ahí?
Sí, doctor.
Sí, doctor.
Bueno, pues creo que tenemos ahí un buen resumen. Tratamos de ir desde tiempos ya que parecieran lejanos, en donde andaban combinando, haciendo las terapias secuenciales de iniciar primero un inhibidor de fosfodiesterasa y después agregarle otro, ¿no? Dependiendo de la respuesta y como lo que dice el doctor Gali o Galier o como se diga, que antes estaban enfocados en la caminata de 6 minutos, como un punto de resultados y ahora lo hacen ya como estamos acostumbrados los cardiólogos a evaluar, ¿no? Los puntos duros finales de mortalidad, rehospitalización, fallas a los tratamientos, etc. No sé si quieren agregar algo más, R3.
No, doctor, eh, hemos visto ahí la historia que nos puso, estuvo interesante porque más o menos, bueno, tomando como parámetro o comparación lo que nosotros hemos visto por ejemplo, en insuficiencia cardíaca o cardiopatía isquémica, el camino que ha tomado el tratamiento en la hipertensión pulmonar, y vimos pues desde que empezaron apenas con monoterapia, después empezaron a combinar fármacos, iniciar doble terapia y ahora pues en el último iniciar triple terapia. Más o menos ha sido el camino que han tomado, viendo los efectos adversos y como comentaba ahorita, pues los desenlaces finales en los estudios que también se han ido modificando. Si bien esto aplica más para el grupo 1, pues probablemente le falte más camino al resto de los grupos de hipertensión pulmonar. Espero que esos grupos se vayan incluyendo, vayan saliendo nuevos fármacos que impacten de una manera más favorable en los outcomes primarios que están midiendo en estos estudios que nos presentó el doctor Nazareno.
Sí, muy bien. ¿Algo más, Poncho o Miguel, que
Sí,
quieran
doctor,
agregar?
digo, pues parecía, o todavía medio parece algo oscuro el tratamiento de estos pacientes y el desenlace en cada uno de ellos, porque pues no se había podido disminuir los eventos cardiovasculares. Parece ser que ahora con esta triple terapia y que podría ser ya una diana terapéutica para irnos hacia el riesgo de los pacientes, pero la verdad es que suena prometedor, pero nuestro medio lo veo muy complicado. El acceso a los fármacos como Riociguat, Macitentan, Bosentan es de alto costo. Difícilmente los pacientes lo pueden pagar. Am- Apenas el sildenafil lo compran y el tadalafil, que es todavía más caro, muchos pacientes no lo pueden costear. Entonces creo que nuestro medio, los desenlaces y el tratamiento va a seguir siendo oscuro por gran parte del tiempo.
Sí, Poncho, de acuerdo. El, sí, se ve muy complicado primero, bueno, como sabemos, no es una patología que encontramos todos los días como la hipertensión o la cardiopatía isquémica. Segundo, el abordaje diagnóstico no es sencillo. Cada vez se ha ido simplificando un poco más, pero se necesitan parámetros que ahorita creo que en realidad para nosotros es abordar como la probabilidad de hipertensión arterial pulmonar, hacer un ecocardiograma, llevarlo a un angiotac y casi con eso pensar que pudiera ser una presentación de hipertensión pulmonar primaria o idiopática, ¿verdad? Pero el descartarlo completamente, por ejemplo, llevarlo ya a una sala de hemodinamia, se puede hacer, creo que relativamente fácil un cateterismo, bueno, relativamente fácil para el doctor Carrillo, el doctor Leiva, ustedes que en algún momento vayan a ser intervencionistas, yo ya ni picar una vena creo que puedo, pero ir preparados para hacer un reto por ejemplo, de ver si tiene vasorreactividad. Aquí se dice muy fácil, ¿no? Pero tratar de hacer un estudio hemodinámico en búsqueda, completar todos los pasos para buscar vasorreactividad y determinar que ese paciente vaya a la terapia con calcio, con los bloqueadores de canales de calcio, no es del todo sencillo, ¿verdad? Este, Igual decir lo que es no reactivo, o sea, catalogarlo como que en realidad ya no tiene reactividad. Y desde aquí es donde ya nos, nos atoramos, ¿no? De hecho, podríamos, obviamente lo tenemos que conocer, es importante que conozcamos todo esto, pero en la práctica, idealmente habría que referirlo a un centro de atención, o de diagnóstico y manejo de pacientes con hipertensión arterial pulmonar. En realidad, como yo creo que ya muchos de ustedes lo saben, pero el punto de referencia que más o menos tenemos es el área de hipertensión pulmonar o de cardiopulmonar en el Nacional de Cardiología, ¿no? Donde incluso de los estudios que presentó el doctor Nazareno, ya viejitos, Tomás Pulido, que es el que se quedó al frente del departamento de cardiopulmonar, ahí en el instituto, pues ha participado mucho en estos estudios. Y el doctor, que ya regresó, pero regresó solamente a investigación, el doctor Julio Sandoval, fueron de los que fundaron esos grupos de estudio de pacientes con hipertensión pulmonar, ¿no? ¿Qué más? ¿Algo más? Miguel, Eric. Ahí está Roberto, ¿verdad? Nada más.
Pues no, doctor, creo que ya comentaron gran parte. La verdad es que estuvo bastante interesante el abordaje de la hipertensión pulmonar, desde todo, como decía Ricardo al principio, o sea, todo lo que se ha ido evolucionando y el gran interés en su estudio. Entonces, pues nada más agregar, y de acuerdo con Poncho, en que pues estamos al menos en nuestro medio muy limitado. En los últimos estudios que se han valorado el beneficio con doble o con triple terapia, si bien hubo mejor respuesta con la triple terapia, la doble terapia, que es algo a lo que pudiéramos acceder, pues también probablemente se puede haber limitado en cuestiones de costos, de tiempo de seguimiento, de apego del tratamiento de los pacientes. Y pues al menos sí es importante tener en consideración todo esto y tratar de referir a los pacientes de manera oportuna a los centros donde se pueda brindar algún tipo de atención, que desafortunadamente en el país probablemente al ser tan pocos, pues también se encuentran muy saturados. Y pues nada más.
Sí, perfecto. ¿Alguna duda, Eric, Roberto, que les podamos aclarar? Todo bien claro. La evaluación del riesgo es una de las partes muy importantes, ¿verdad? Cómo se van moviendo dentro de los riesgos bajo, intermedio o alto para el abordaje terapéutico. ¿No? ¿Todo bien,
No,
Eric,
doctor,
Roberto?
todo claro, doctor. Pues
Sí, doctor, gracias. Todo claro.
Muy bien. Bueno, jóvenes, entonces veamos, lo voy a terminar. Si quieren de rato platicamos a ver si quieren que seguimos la próxima semana o nos tomamos 15 días de vacaciones. No ustedes, obviamente. Ok. Yo digo de sesiones tempranas a las 7. Ahorita lo platicamos. Nos vemos en unos ingresos, ¿no? No, ¿verdad?
Sí, hubo un ingreso a piso, doctor. Un paciente de 61 años que refirieron de Salinas, lo trajeron por una bradicardia de 30 por minuto, pero aquí desde su ingreso ha estado con frecuencias de 45, 50, con un bloqueo AV de primer grado. Pero venía un poco somnoliento. La familiar dice que así es él, es como que tiene hipoacusia severa, apenas escucha y también responde muy lentamente. Lo dejamos en piso y le puse un holter a ver si ahí captamos que haga alguna otra alteración del ritmo, pero pues ha estado estable.
Sí, si hace alguna otra alteración del ritmo para referirlo al centro colocador de marcapasos. Bueno, ok.
Sí,
Perfecto, ahorita revisamos los electros. ¿Qué edad tiene el venerable?
61.
Ah, chihuahua, no está viejito.
No, de hecho no tiene diabetes ni hipertensión, nada más dislipidemia y en los laboratorios pues todo normal.
Bueno.
Nada
Ok.
más la T4 libre está un poquito baja, pero ayer se lo comenté al endocrino y dijo, no pasa nada con la tiroides, es uteroide enfermo y tiene otra cosa.
Bueno, ok. Pues para ver qué sale en el holter. Órale. Entonces nos vemos de rato. Gracias.
Hasta luego.
Bye.